So let's continue on with talking about some cardiac stuff. First off, a little bit of antibiotics, just in case you guys were missing antibiotics at all. Here, okay. Really, the biggest cardiac infection you might run into is infective endocarditis. Have you guys talked about this previously? Good. Okay. So basically, it's going to be this bacterial infection of the lining or the valve within the heart. And again, these can be very, very tough because once you get these kind of vegetative growths, they can be difficult to penetrate with our antibiotics, and which is why they're so dangerous. And in some cases, you may even find you have to actually replace the whole valve just to get rid of it, right? Now, things that make you more at risk for developing endocarditis include advanced age. If you're a male, you tend to be more at risk. Injection drug use. Again, there's a lot of different infectious diseases they're more at risk at, but again, endocarditis is one. Poor dentition. So again, sometimes with dental infections, you can see kind of hematogenous spread of some of these kind of mouth bugs that can eventually cause an infection on endocardium. If any kind of structural valve or heart disease, or if you've had, like, say, a prosthetic valve put in, right, or any kind of intravascular device, say, for instance, you have, say, like a central line that's placed, like a port, that could also be another source for infection as well, right? So several things that kind of put these patients at risk. So obviously, you can start off with this kind of thrombus on the abnormal endothelial surface, and then you'll end up getting this secondary infection with these bacteria, right? So you can imagine if you have, like, foreign material, like a prosthetic valve or something, how it would be very easy for kind of some of these, thrombus to form on it, and the bacteria kind of latch onto that. And so they start to proliferate, and they get these vegetations there on the surface. So causative bugs. What's going to be most common? You're going to see a lot of gram-positives here. So you can see things like Staph aureus, Viridans group, Streptococci, Enterococcus, even Streptococcus bovis is going to be another one you don't see too frequently outside of endocarditis. And then we can talk about these haystack bugs, and these are going to be some gram-negative things like Haemophilus Acinetobacillus. These kind of odd bugs you really don't see very often. Occasionally fungus, occasionally some gram-negatives, but most of the time gram-positive. So our coverage is going to mainly focus on some of these gram-positive bugs. All right. So again, therapy should be geared towards the culture. So how would you culture this type of infection? Yeah, you do blood cultures basically. So hopefully you're going to have some kind of spread of the bacteria through the bloodstream, even though it may not seem like a true bacteremia. You can at least measure them off of that. And again, when you're piercing the skin in order to get blood, what do you have to worry about? Contamination, right? So oftentimes you see like staph epi on a blood culture. You want to make sure you check two different sites, right? So oftentimes you have blood cultures from both arms or both two different sites. So that way, if you see staph epi in one, it's probably a contaminant. It's probably not truly the causing disease. If you see staph epi in two, that makes you think, okay, it's more likely to be a true infection there. So one thing to kind of keep in mind with blood cultures. Anyway, the empiric therapy should be geared towards these gram-positives. So again, we're covering for MRSA and MSSA, Streptococci, Enterococcus, all of that should be covered here. And we prefer bactericidal antibiotics because, again, this is something that can be very difficult to treat, it can be very difficult to penetrate that vegetation. So you got to be able to get something that's going to kill off those bacteria. So the thing we want to choose first is going to be vancomycin. It's going to be our go-to drug to start off with endocarditis. Okay, especially if they have to come back with MRSA, this is going to be the main drug we're going to start with. And notice the treatment time, very long compared to a lot of other types of infectious disease. A lot of patients might be in the hospital for several weeks to months just getting treatment for this, because most of the time this requires parenteral therapy or IV therapy. Now, if it comes back and you're growing either Viridans streptococci or the Streptococcus bovis, these tend to be highly penicillin susceptible. So this is where we could actually utilize, and I've only seen this once or twice, where we've actually used continuously administered penicillin G. So you can actually just get away with straight penicillin, but given as a continuous infusion 24/7, or you can give it up to 4 to 6 times a day. And it kind of makes sense why you give it that frequently, right? Because how is it concentration or time dependent? Time-dependent killer, right? You want to keep it above that MIC, so you need to give it pretty frequently. Or continuously would be fine because it keeps the level set throughout the entire day. Rocephin could also be used potentially, or vancomycin if they could not receive penicillin or cephalosporins. That would be fine as well, okay? And then what's interesting, we can also use gentamicin. So remember, what does gentamicin normally kill? Gram-negatives. Why are we using it for something like, this Viridans streptococci? Well, you get some gram-positive synergy here. This is one of those few cases where, again, you're using two drugs to cover the same bug. We saw that with Pseudomonas and pneumonia, but you see this here as well. So you can either give gentamicin daily or maybe throughout the day, and it helps us to shorten the course of therapy. So say instead of 4 weeks, we're going to start with use 2 weeks instead, because you just get a better synergy there. Two different mechanisms, both cell wall and also on protein synthesis, they can have a better kill there. Obviously, you got to watch your renal dosing, you got to watch out for otic problems, things like that, but you guys already know about all the side effects there of gentamicin. Let's see, if there's other streptococcal species, most of them tend to be penicillin sensitive. So just follow your cultures, whatever it ends up saying. So again, this is something where you start off with vancomycin and you scale down based on what the cultures come back as. Intercocci, you can use, you can't really use penicillin because it ends up being kind of resistant to that. But you can get over that synergy or that resistance hump by using gentamicin plus something like penicillin, ampicillin, or vancomycin certainly will get it as well. Okay. And then for staph, if it's MSSA, this is where we like to use our anti-staphylococcal penicillins, so like nafcillin, oxacillin, even Ancef or that first generation cephalosporin would be fine, plus or minus gentamicin. Gentamicin just helps us to shorten up how long we have to treat for. And obviously MRSA, vancomycin is the one to go with. Now, if you have some of these haystack organisms, we'll see this is about 5 to 10 cases of kind of native valve or kind of natural valve endocarditis in non-drug users. A lot of them end up being susceptible to ampicillin, but over time you start to see more resistance to that. So we can end up utilizing a beta-lactamase inhibitor with ampicillin. So we can use something like Unison, which is the ampicillin sulbactam would be fine. Cipro you could also potentially use if they had an allergy, or ceftriaxone could also get this as well. Right, so you have a couple options if you would have one of these haystack organisms. All right, then injection drug users. This isn't really related. It's just I want to show off my Saturday night from the weekend. I'm just kidding. It's insulin, I swear. No. Okay, so anyway, so looking at IV drug users, they tend to have kind of an interesting mix of different bugs that could be causing this. So again, when they're injecting drugs, do you think they do this under a nice sterile laminar flow hood when they're mixing their drugs? No, they're doing this like in their bedrooms or wherever it happens to be. They are usually doing things like using cotton to help filter out a lot of their substances. I don't know if you've ever seen like TV Breaking Bad or something like that, but yeah, that's probably not too far off from what they're actually doing. So what you end up having is a lot of injection of particulate matter. Especially if you ever see someone who crushes up pills and injects those, all that talc and all those inactive ingredients can cause issues like pulmonary embolism, stuff like that. But for our purposes for endocarditis, you can end up seeing tricuspid damage due to this particulate matter that makes it much, much more likely for bugs to kind of grab onto that and cause an infection. Also skin flora, because obviously they're injecting, they're probably not using some nice iodine to clean off the site before they inject. They're probably just going, also use of saliva. Gross. But you can see lots of, kind of the mouth bugs that could also be causing the disease there as well. Some common bugs, Staph aureus in more than half the cases. So again, vancomycin is going to be really important to go with here. Streptococcus, Intercocci as well. And then also more likely to see things like gram-negatives and fungi as well could be potential causative agents.
I'm just the use of saliva. I have, in what way?
If they are trying to clean the needles off, say if like maybe from the last person, that could be one thing. Trying to solubilize any of their drugs. I mean, I haven't done this in a while, so maybe they've thought of some other stuff to do. I don't know, hard to say. Listen, as a pharmacist, you have to try all the drugs in order to know about them, so jeez. Okay, so the other side of this is that, patients with prosthetic valves, they tend to be more likely to get endocarditis as well. Oftentimes, you're going to find failure of the antibiotics. A lot of times, they have to require surgery to get that replaced actually for a second time. But generally, it's going to mimic the treatment of native valve endocarditis. But for staph, because again, these are so difficult to treat, we actually end up using a triple drug regimen. So we use something either like vancomycin, probably to start with, until we get a culture back, Ancef, nafcillin, oxacillin, some kind of anti-staphylococcal drug, plus rifampin. We haven't talked about that. Oh, we did with tuberculosis. We already talked about rifampin. And again, what does rifampin do to drug levels typically? What does it do to CYP enzymes? It induces, right? So that would do what to drug levels that are metabolized by, say, CYP3 or 4? Decreases them, absolutely great. And then also use gentamicin for that gram-positive synergy. So we use a triple drug regimen. And again, MRSA tends to require surgery more often than some of the other causative agents as well. So I mentioned rifampin. I'm sorry the picture it got goofed up again. But anyway, we kind of talked about this already. Induction of CYP enzymes is super, super important. Again, what does it turn your urine color? Yeah, orangish reddish. Yeah, absolutely. The big thing to note with here that's kind of new material is that resistance can develop to it pretty quickly, right? Just like we saw with TB, you don't use rifampin by itself. It needs to be used with other agents to prevent resistance. And this should actually be started last out of the bunch. So you would start with gentamicin, vancomycin to start out with, and then you would add on rifampin after those other two are going. Basically, if you did this first, you can more likely to see resistance develop to it. It's kind of an interesting thing where you need, the timing is important of these medications. Okay, so I won't belabor that point any further. So as far as prophylaxis goes, so especially at patients who have a history of having prosthetic valve being placed in, they are oftentimes given prophylaxis to prevent infection to occur from the first place. High-risk patients I mentioned are prosthetic heart valves, they have a history of infective endocarditis or any kind of congenital heart disease, or if they have like a transplanted heart, any kind of valvulopathy, anything like that. These guys are more at risk for developing infection, so they need to have some sort of prophylaxis on board to make sure they don't get infected to begin with. So some relevant procedures that you may need prophylaxis for include things like dental work, other than like routine cleaning and kind of like, root canals or anything like that. It would definitely be at the highest risk for having some of those mouth bacteria kind of translocating via the bloodstream to the heart valve, or especially any kind of gingival tissue manipulation or perforation, anything like that. Certainly the respiratory tract, so they had like maybe a tonsillectomy, bronchoscopy would also be high risk, and then any kind of skin or musculoskeletal tissue, so in surgery, things like that, they should be on prophylaxis regardless. Basically, you would take amoxicillin, PO, just 30 to 60 minutes beforehand. So if, like, for instance, when I was doing rotations and I was in a Walgreens for a month, you have people that would come up with an amoxicillin prescription for like 2 doses, and I'm just like, that's weird, why would you only get 2 doses? Well, they're probably using it for this sort of thing, right? Other drugs you could use if there was an allergy, cephalexin, clindamycin, ezetimibe, all those would be fine as well. Again, you're not giving it to cure a disease, you're just trying to prevent it from occurring in the first place. All right, another condition you might run into is called rheumatic fever. Anyone know where you might get rheumatic fever from? Absolutely. Yeah, so again, I apologize for my pictures all being goofy. I thought I fixed all these. Anyway, so again, these are going to be kind of a non-suppurative complication of pharyngeal infection, usually group A strep, usually a couple of weeks after the pharyngitis. So you see a lot of like arthritis, carditis, all these kind of different manifestations here. But it's one, especially in outside of developed countries, this tends to be a leading cause of cardiovascular death within the first 5 decades of life. So really young people kind of dying from this, unfortunately. So obviously we want to treat that. Big thing obviously is to treat with antibiotics up front. So using things like, what's your go-to drug for strep pharyngitis? Bicillin could work. Penicillin. Amoxicillin is another good one. We use that most often for kids. So again, just like you're seeing, there's lots of gray in medicine. There's lots of right answers. So there you go. There's 3 right there. Obviously, one of the things you can see is heart failure that can develop after this, so you manage that. We'll talk about heart failure later on. It's cardiology section, and then also anti-inflammatories. This is another one of the big things we're going to do if you did have rheumatic fever. So obviously, for antibiotic therapy, amoxicillin and penicillin is going to be fine. It's going to help with that group A strep. For the carditis, we'll talk about CHF later, but in some cases, you may even need things like valve surgery, but aspirin is going to be a big one. So if you had a patient with acute rheumatic fever, they're going to be getting high-dose aspirin, basically 4 to 8 grams a day in adults, and this is actually going to help with dealing with those kind of inflammatory symptoms. So it's kind of our go-to drug for that. Who kind of continues until you have a resolution of symptoms like the arthritis and the fever. And in some cases, the more severe cases, you may actually need corticosteroids to kind of help deal with that inflammation from either kind of a stronger standpoint. So, all right. I guess I'll cut it there. I'll give you guys a break. You guys have a test tomorrow, right? Okay. And a quiz. Any questions before I let you guys go? Okay, we'll come over and hit the hyperlipidemia stuff next time, and then we'll go on from there. Thanks. Okay, any questions from the last time we had class? I barely remember last time we had class. Seems so long ago. Anything at all? Okay, so we started some introductory cardio stuff. We're going to continue on. First off, talking about anti-lipemics. What do we use anti-lipemics for? What does that mean? Anti-lipids in the blood, essentially, right? So basically, those are going to be for hyperlipidemia. These are meds that you can utilize for that. So 2 primary sources of fats that we get through the diet are primarily we're going to see dietary fat and cholesterol, usually like triglycerides and cholesterol itself. So typical American diet, obviously this can vary pretty widely depending on the patient you're talking about, but say like 100 grams of triglycerides, 250 milligrams of cholesterol. And we can see that there's going to be some interconversion here between triglycerides getting converted into cholesterols. Now, why do we care about this? Why is this important? No. So, you have too much fat in the blood. What can you possibly see occur? Atherosclerosis. Yes, that is the big thing we're worried about, right? Because if you have more atherosclerosis, what happens then? If these plaques form, right? You have narrowing of what type of vessels? Coronary vessels. Yeah, that's not good, right? Because if you have poor flow through your coronary vessels, you end up getting myocardial ischemia, and then guess what? Then you die. So this is why this is important, right? Because we want to look at these things that are happening, this kind of inflammation cascade that occurs due to having too much fat in the blood, and this is the medications we're going to use to fix this. Big reason why we care about this is because these drugs, especially when we talk about the statins, everyone's heard of a statin before, correct? Most people have. You will see that these are going to have really good effects on improving mortality. This is going to help your patients to live longer, which is why it's really important we know about these medications. A lot of your patients are probably going to end up being on a statin at some point if they have any kind of cardiovascular disease. We'll talk about why that is. So anyway, so we're going to look at the kind of the process of getting dietary fats into the systemic circulation, kind of what happens in order to generate our cholesterol that we're worried about. And when you hear bad cholesterol, what is another name for that? Yeah, low density lipoproteins, and then when you hear like good cholesterol, HDL, they're high density lipoproteins. We'll talk about why they get those kind of that nomenclature. Have you guys covered this anywhere else yet? I think we've talked about this a little bit in physio. Probably could have gone into more detailed there, but anyway, so we'll talk about how these get formed. So basically, one of the big things, and I only go through this process because this is important for understanding how a lot of these drugs are going to work and why they work effectively as they do. And so one of the first things you're going to see, obviously, is when you have dietary cholesterol coming in through the food that you're taking in the GI tract, how do we break that down? How do we make it more digestible for our enterocytes and then also like the liver? So we have things like lipases, which are going to be good for helping to start break that down. That comes from where? The pancreas, yeah, right, because there you have proteases, lipases, amylases that are coming from the pancreas. So lipases are important for that. And what else helps it break down the fat molecules into more kind of digestible particles? They turn into chylomicrons. Bile salts. Remember the biliary tract and the bile salts that get sent out, right? Remember what those are made from? Those also get made from cholesterol, right? So we're using these molecules, these bile salts. And so these biliary cholesterol is really important for helping to break down the cholesterol that coming from the GI or coming from the dietary intake. And you start to break these down into this kind of micellar cholesterol, and eventually it will get turned into what we call these chylomicrons, right? The cholesterol gets turned into these esters form. We'll show you some pictures of that in a second. But basically, you're able to absorb these much more easily as they get broken down into smaller and smaller molecules, and the bile salts are really important for that. Notice the bile salts are also going to be getting reuptaken through these enterocytes. What do you call that process of like sending it out through the biliary tract and reabsorbing it? Call that enterohepatic recirculation. That's actually a really important concept for some drugs because that actually helps to extend the half-life of some drugs. So for instance, like your estrogens, when you're looking at your oral contraceptives, you have them being excreted through the biliary tract because they get conjugated with some cholesterols and they get sent out. Bacteria break them down into kind of a reusable form, then you reabsorb them, right? So that's really important for extending the half-life of that drug beyond what you would just expect based on just a kind of generic half-life in the bloodstream. So again, all this stuff is going to kind of come back around as we'll see. Basically, what you're seeing here is that you're going to have dietary fats going to be carried by these chylomicrons, right? So it's going to be made up partially of cholesterol esters and also triglycerides. You can kind of see here that as these molecules get more and more kind of metabolized, they're going to have a higher percentage of cholesterol esters. Here, you're going to notice the chylomicrons have a very high amount of triglycerides, here again coming in from our dietary intake, and also from some of the bile salts that we've kind of sent out. So you get high triglyceride content. You're going to notice that these are going to mainly reside in the core here, and they get hydrolyzed by this lipoprotein lipase, or this LPL, and that's going to start to produce these chylomicron remnants and also free fatty acids and glycerol. These are what gets uptaken by the liver, where it can then be processed into actual cholesterol that can be sent out into, and these molecules will be sent out into the bloodstream essentially. So you're going to have different receptors on the liver that are important for kind of taking them into the cells. So we have things like LDL-like receptor proteins, right? So the chylomicron remnants will interact with that and they'll allow for uptake into the liver. They can be converted, things like triglycerides and fatty acids into cholesterol eventually. And so we can use these chylomicron remnants for lots of different things. We can do things like, cell membrane synthesis, right, for producing new cells. We can use this for hormone synthesis. Some of them can be disposed of as bile acids, right? So they can, again, you see that recirculation process already starting up here very kind of early on, okay? So Carbohydrates and fatty acids can also, again, not only from the dietary intake, but also from just circulating in the bloodstream, can also be converted into these triglycerides. This is again why you see things like, high amounts of carbohydrates in a diet, eventually get stored as fat, right? So this is kind of the beginning of that process here, because again, they're getting converted into those triglycerides. We've kind of gone through that process previously in physio. Anyway, so when you have these triglyceride-rich, very low-density lipoproteins, they're going to end up being secreted by the liver. So we're going to call this VLDL, from very low-density lipoproteins. They're primarily going to be made up of these triglycerides. Right, so when you're measuring triglycerides, if you do like a lipid panel for your patient, you're primarily going to be measuring these VLDL particles, right? Also, some of these, eventually, as you get more metabolism, you're going to have this intermediate density lipoprotein, again, a higher percentage as you get more metabolism of cholesterol esters, as you get rid of more of those triglycerides. Okay, so again, when you measure triglycerides, this is what you're kind of measuring, as a kind of indirect measure. So anyway, as I mentioned, in the plasma, still more LPL activity. You're metabolizing more of those triglycerides, using them up, and then eventually it turns into that intermediate density lipoprotein. As you continue even further, this is where you're going to get LDL, right? So again, notice here the LDL molecule is primarily going to be cholesterol. That's why I call it low-density lipoprotein. It's not completely made of cholesterol yet. That's where you're going to see more in our HDL. Still have some triglycerides available, and I'll show you a picture what this looks like kind of on a micro scale. The big thing here to note is that you have an LDL receptor. So this is really important for getting rid of LDL particles. Primarily going to find these, on things like adipose tissue for uptake there. You can find this more for our purposes. We were concerned about having this on the liver, right? Because if you have too much LDL floating around the blood, this can become, you can cause inflammation from having too much of this around. This is where you get a lot of that atherosclerosis, is you can have deposition of this into the coronary vessels, and this is where you have the plaque starting up and all of that. So it's really important. You want to clear and get rid of this LDL, right? Because this is not, some of it is good, right? You want to have some amount of it, but you don't want to have too much, obviously. And so this is where the LDL receptor is going to come into play, because the more LDL receptors you have, the more active they are, the more able you are to clear from the blood. Okay, so a lot of our drugs are going to be focusing on getting more LDL receptors out on the hepatocytes, so that way we can get rid of the LDL particles. Okay, so we're going to see there's also going to be some apoproteins that are going to be located on the surface of the LDL molecules, and that's going to be really important for interacting with these receptors, as we'll see in just a few minutes here. It's just kind of, again, nothing to really kind of memorize from the slide specifically, except for just kind of some kind of key characteristics here. But notice here how chylomicrons down to VLDL all the way to your HDL, that you're getting less and less triglycerides here as you get more of this metabolism occurring to that lipoprotein lipase. Now, the really big thing to know as far as catabolism goes, that most of these, as you get up to the LDL, is going to be, being hydrolyzed by the LPL. But eventually, when you get here to the LDL, this is where this ApoB100 protein is going to be really, really important for interacting with the LDL receptor. So you have to have this on the kind of the surface of the LDL molecule to be uptaken by the hepatocyte to be gotten rid of either bile salts or whatever else you're going to use it for. And so HDL is going to be really important here as well. That's kind of our good cholesterol that we know about. Primarily, this is going to be a transfer of, they're moving kind of more cholesterol esters to this VLDL in the LDL, and then it eventually gets uptaken by the liver, where it can then be utilized for whatever process you need it for. So kind of a micro scale, you notice here on the inside core of a LDL molecule, you can notice here it's made up of these cholesterol esters and the triglycerides. Kind of have these phospholipids and other unesterified cholesterols kind of forming this membrane here that kind of holds everything in. But the big thing to know are these apolipoproteins, right? So these are the things that are going to be on the cell surface that interact with the receptors. The fats themselves can't really do that, but the proteins here are what's going to interact with the receptors. Okay. So looking at the LDL particles, again, they're coming out from the IDL. They typically have a half-life around 1.5 to 2 days or so. And this ApoB100 is the only protein that interacts with those LDL receptors. So you have to have that there. And so this is the primary way they're going to clear from the blood. And so if we can do anything to influence the number of LDL receptors that are available, that's going to be really good. And so we'll talk about several drugs that can have a direct effect on that. Most of those receptors are found in the liver. So that's, again, where most of the catabolism is happening here. But less activity, you're going to have more LDL particle accumulation. That leads to more atherosclerosis. So we know, we've seen patients that have that correlation between high LDL levels, cardiovascular death. So if we can get those levels down, we see that they tend to survive for longer. This is where we've kind of done these really big studies. Anyone ever heard of like the Framingham study? It's a big study. I kind of mentioned it. I thought I mentioned it in one of the Epi bio stats. I might have mentioned on the Epi part, actually, on the first lecture there. So I will forgive you guys for not watching that yet. But basically, this is, they do these really big studies, and when you look at like cardiovascular studies, like typically they do it in thousands and thousands of patients. So like some of the evidence we have for these drugs and using them to increase mortality, or I guess not increase mortality, but extend life, I should say, is really strong because we have so many patients here, and we know that these correlations are really good, and we have some pretty good randomized controlled trials and things like that. The Framingham Heart Study. Yeah. A lot of your risk calculators actually come about from that. So if you're doing like risk of death due to cardiovascular complications, like the Framingham study generates a lot of that stuff. But anywho, so you can kind of see on this picture here, we have a LDL molecule. Notice here it's going to have this ApoB100 protein that interacts with the LDL receptor. It will be taken up into the hepatocyte. You can do things like get rid of some of the amino acids. You can utilize the cholesterol, all that good stuff. You can utilize for bile salts or submembrane production, hormone production, all those kind of things. And then eventually you're going to recycle that receptor back onto the surface, right? So anything we can do to keep this receptor, or keep more of these here, the better we're going to be at clearing the LDL from the blood. So, and again, you can see genetic deficiencies in this where people will actually be missing some of these LDL receptors. And you can see if you had a homozygous familial hypercholesterolemia, they can have levels up to as high as 1,000 milligrams per deciliter. Anyone know what like a normal like LDL concentration would be? Yeah, so you see like 100, maybe it's like 150 be kind of high, but let's say like 100 is like considered normal, right? That is usually kind of a goal we're shooting for to get people less than in a lot of cases. Again, that's 10 times higher than that because they just don't have these receptors available. So again, a lot of our medications we're going to be using are trying to influence that LDL receptor concentration, get more of them available to clear that LDL. So again, your typical serum cholesterol is made up around 60 to 70% LDL. 20 to 30% is going to be made of HDL in a lot of cases. Some people have kind of some variations in here. Again, this is not everyone's going to kind of fit into these norms. But the VLDL is going to make up the next 10 to 15%. And again, when you're measuring a lipid panel, that VLDL would be represented by the triglyceride that gets reported there, right? Because again, most of the triglycerides in the blood get carried by this VLDL and some of the IDL particles. Okay, so we're going to look at some drugs that are going to be affecting how we manage fats in the blood. Some of them are going to be focused on preventing absorption from the GI tract. Some of them are going to be focused on, say, like liver production of cholesterol. We're going to go into more detail on all of these, but we'll look at them and we'll see which ones are going to be our first-line drugs. We're going to see which one's good for people with who are pregnant. You're going to look at all these different things to choose which drug is going to be best for our patients. So here are the different categories we're going to have here. So we're going to start off and talk about our HMG-CoA reductase inhibitors. So again, that's not really a very sexy name, so we just kind of shortened it down to statins. We just call them that, right? So again, this is going to be our gold standard. This is our go-to set of drugs we're going to use to treat hyperlipidemia. We're also going to have things that will block absorption of cholesterol. So this is called Ezetimibe. We'll have our Fibrates, our bile acid sequestrants, nicotinic acid, and then also this newest class called these PCSK9 inhibitors. Okay, so we'll go into more detail on all of these in just a moment. Starting off with our statins. Talk about these the most because these are our most important class here. They have the biggest track record for efficacy and in mortality improvements in these kind of big heart studies. So again, it's pretty easy to know which drugs are statins because they end with statins. That's pretty good. Most people have heard of things like simvastatin or Zocor, atorvastatin, Lipitor, rosuvastatin, Crestor. Most people have kind of heard of these drugs. We're seeing a lot of commercials about it because a lot of these, when you get a new one that comes out, it's kind of a blockbuster kind of med because a lot of people have hyperlipidemia, so you have a lot of people that you can potentially treat with this. So that way, when you come out with like a new one like pitavastatin, you're like, oh, this is the new hotness. Like everyone should be on this drug. Let's get lots of money back from all the development costs and all that good stuff, right? So anywho, the way that they're going to work, and again, I'm not going to have you memorize this whole process here of how you start with acetyl-CoA and eventually convert it down into cholesterol. The big thing to note here, though, is that we're actually inhibiting this enzyme called HMG-CoA reductase. So if you ever hear HMG-CoA reductase inhibitor, that's just referring to a statin. It's just kind of the long-form name of it. But basically, by blocking this early step in the process of generating cholesterol, you kind of stop the liver from producing that at that point, right? So you're stopping it very early on in the process there. Why that is effective for lowering serum cholesterol is because by decreasing cholesterol synthesis here in the liver, right? So this is the hepatocyte, this is more the systemic circulation. You're going to decrease that intracellular cholesterol, right? So again, and a lot of this stuff goes back to these negative feedback loops, right? So if the hepatocyte have enough LDL, it doesn't really need to expose a lot of those receptors to the cell surface because they're like, well, I have enough LDL to do what I need to do. I can start to take these back and keep them more kind of internal and save them for when I have a deficiency. we're causing that deficiency now by giving a statin. So you see more of these LDL receptors are going to be pushed to the cell surface. That means you're going to end up having more uptake of LDL particles, primarily as they get exposed to the hepatocytes. So by doing that, you're going to have increased LDL receptor mediated uptake of LDL and some VLDL, these remnants. You're going to have decreased serum LDL concentrations. You should have decreased VLDL remnants, right? So your triglycerides should go down as well. And then you'll see those intermediate density lipoproteins also decrease. So triglycerides go down, your LDL goes down. You'll have some modest increase in your HDL. And these are all good things. These are all the right direction for these numbers that we want for them, right? Kind of make sense? So we also have these pleiotropic effects. So has anyone ever heard of the term pleiotropic? That means you can wow your friends with this 99-cent word. So basically, pleiotropic means we get these kind of additional benefits from giving a drug. So even though this isn't related back to the direct mechanism of the drug, you get kind of additional benefits. So for instance, if I had glaucoma and I was using something like bimatoprost to lower intraocular pressure, and all of a sudden I have these beautiful, long, luscious lashes, that would be a pleiotropic effect, right? So again, it's kind of an additional benefit that, you know, maybe I just want long lashes, who knows? But anyway, but you get these pleiotropic effects of statins. You're going to see things like they improve endothelial function. They help to decrease these inflammatory markers that we know are associated with atherosclerosis and cardiovascular death. They do things like inhibiting platelet effect and antithrombotic effects, right? Because again, when you have those plaques, when they rupture, what tends to bind to them to cause, you know, coronary vessel occlusion? A lot of platelets, right? Because this is why we give we'll talk about drugs we can use for acute coronary syndromes, but this kind of goes back to all of this. So again, they're going to help with things like blood pressure to some mild effect. They're going to help to decrease, you know, things like, you know, ischemia, reperfusion injury after you have, you know, something like a heart attack. So these are all really good effects, and this is why statins have the biggest track record. This is why we like to go for them as our gold standard, and this will be reflected when we look at the guideline recommendations. Okay. So I'm not going to have you memorize this whole chart, but just some of the things I kind of want you to take away is to just note that, you know, all the statins are going to be a little bit unique in things like the half-life, things like, you know, what effect food might have on their concentrations. You know, some drugs you may want to give with food to get better serum concentrations, things like lovastatin. But for instance, with the metabolism, this is really important as far as drug interactions go, because this is a very common one, because a lot of people are on statins, and if you don't check their med record and you add something on board, so say for instance, you know, they are on lovastatin for their hyperlipidemia, all of a sudden they come down and they have pneumonia, right? So what might you prescribe for an adult with pneumonia? Yes, you would prescribe antibiotics. What type of antibiotic would you prescribe? Like a macrolide, right? Because if you're worried about, you know, atypical bugs, you might say, let me give you ezetimibe, or let's say erythromycin would be even more potentially problematic. Erythromycin, what does that do to CYP3A4? Inhibits it, right? So you have a 50-50 chance. Yeah. So it actually inhibits 3A4. So by inhibiting that, what happens to your lovastatin concentrations? They're going to go up, right? So that's one of the big things you worry about, these interactions here. You know, on the other hand, if I were to give them like Rifampin, if they came down with endocarditis, what could that do? That would induce 3A4, right? So that induces 3A4, your levels would drop. So maybe your LDL would start to go up because of that. So again, you have to be careful of this, because if you screw it up, you can cause some very significant toxicities, especially with the enzyme inhibitors. So we'll talk about a few examples of those just a little bit later. But just be careful, you know. And if you have someone who is on, say, an enzyme inhibitor, like a 3A4 inhibitor, and you needed them to also be on a statin, well, you can pick one that has minimal CYP interactions, right? So you can do something like, say, pravastatin might be okay, or maybe something like rosuvastatin or Crestor would be a good option there. Now, what might limit me from switching a patient over to one of these type of drugs? Yeah, cost might be one of the big things. So like, what does their insurance cover? You know, maybe they didn't tolerate rosuvastatin very well because they had toxicity, even at, you know, relatively low doses. So everyone responds a little bit differently here, and you have to take these factors into account to make sure they're not going to get toxic, and they're also going to have, they're going to meet their goals essentially for getting their LDL reduced, and that way you can see, you know, improved cardiovascular health for them. So again, you'll also see that with statins, you tend to get a synergistic kind of dose response when you add on other drugs. So if you don't get really the response you're looking for with just one drug by itself, which is usually going to be a statin, you can add on other drugs with different mechanisms. And so this is why it's important to make sure we have kind of rational decisions on what additional mechanisms we're going to try to get kind of better effects. So for instance, if you're looking at, say, HDL concentrations are going to be up here in these upper two lines, whereas we have LDL concentrations down here. Say, for instance, I were to use, say, just a, we'll talk about bile acid sequestrants, which are otherwise be known as resins. We'll talk about those in a little bit. Kind of notice, pretty decent response with our LDL concentration lowering. You see that the LDL lowering with the statins probably even better than that. But if you add the two together, it's going to be more than the sum of its parts essentially. So you get synergistic effects there. Begin by using two different mechanisms. Similarly with HDL, you can end up seeing additional benefit by adding on another drug that can work with that, right? So just be aware, if you see patients on two drugs to affect their lipids, like it's usually because they didn't get a good enough response out of the first one, right? And the other thing you can look at is with the triglycerides, you tend to see that the higher the triglyceride content is to begin with, the bigger effect you're going to have by giving even equal potent dosages of these different drugs. So for instance, with simvastatin, if it's less than 150, which is generally a goal kind of concentration for triglycerides, if it's less than 150, you don't really get a lot of percentage lowering there because again, the body has a decent amount, there's mechanisms in place to make sure you kind of maintain a healthy amount of triglycerides. However, if you were to bump it up to say 150 to 250, now we get a 20% reduction with this, or perhaps we even get if it's greater than 250, we get like a 28% reduction. So the more triglycerides you have floating around in the blood, the more likely you are to drop it down with these doses of statins. So it's kind of a dose-dependent effect based on the pre-existing level. All right, so adverse effects to statins. This is really important to understand because again, you want to recognize, if patients having an adverse effect or if something else is going on here. But generally, the statins are going to be the best tolerated out of this group of drugs and also the most efficacious. So you get the most bang for your buck and also kind of the least toxicity. But you want to be aware of what kind of monitoring you need to do for these patients. You need to be aware of potential side effects that can pop up here because again, when they do happen, they can be pretty severe. So for instance, GI intolerance, maybe flu-like symptoms. Some of this can be dose related, so in some cases you may be able to reduce your dose and get around some of this stuff. But things like increase in liver enzymes. So LFTs are going to be one of the things you monitor at baseline, and you're going to follow up with them. You may do it at 6 weeks, maybe at 3 months. But, in say a half to maybe 2.5% of cases, you're going to see a dose-related increase in their LFTs. So you're mainly monitoring like their AST, ALT are the primary ones we're looking at there. Serious problems tend to not occur for most patients because again, most patients tend to do very well with these statins. But if they have pre-existing hepatic disease, that could be predisposing them to more injury, or if they have something else on board that is inhibiting the metabolism of a statin, you're going to see those levels rise. More likely to see toxicity there, right? So you need to be careful of that. If you do see a bump in their LFTs, and usually you're seeing like, if it's just, if it doubles, probably not a big deal. If it goes from say like 30 to 60, I'm not too concerned about that. Usually once they get above like 3 times the upper limit of normal, that's when I wanted to start be concerned about it. And I'll say maybe I'll drop their dose, maybe at 10% and see how they do, right? So they'll come back and recheck it again and see where it goes from there. So you can either do that or you can discontinue it. And if if it had pretty significant rise in LFTs, you can discontinue until it gets back down to normal and then start at a lower dose or maybe a different drug potentially. So the other big side effect you can worry about is going to be these myalgias and then potential myopathies that can develop from this. Again, exceedingly rare in a lot of cases unless you again have any impaired clearance of the drug. So if you have like hepatic insufficiency or if they're on other inhibitors that can block metabolism, this can lead to problems. Rarely can end up in rhabdomyolysis, which what is that? Yeah, so what would a patient presenting with rhabdo complain of? Yeah, dark colored urine and severe muscle aches, severe myalgias would be the other big thing. So, if you started out, say you have like a 300-pound guy, very sedentary, you start him out on a statin to try to get his lipids in order, and he comes back to you and he's like, yeah, it feels like I just ran a marathon, I didn't even get off the couch but to change the channel once or twice. That could be a sign of like, oh, maybe he's having some myalgias related back to this. Could be dose related, could be hepatic insufficiency related, could be drug interaction related, right? So you need to be aware of that. But again, dark tea-colored urine, you got to watch out for that because they complain of that and warn them beforehand, so that way they know to go ahead and make sure they discontinue therapy and they need to come get checked out immediately because what can be a complication of having rhabdomyolysis? Yeah, kidney failure can be one of the big ones, right? Because all that myoglobin floating through the kidneys, if they precipitate out, that can be very significant, damage done in the kidneys. You can see permanent renal failure in some cases, so you got to be careful with that. All host of other problems that can happen too, but the kidney failure can be one of the more long-lasting effects there. So anyway, I don't know if anyone is on Reddit, but there's like a fitness subreddit, and so there's always people every once in a while, usually around New Year's time after New Year's resolutions, but they'll post a picture and they're like, is this pee normal? And it's like cola colored, and you're just like, oh gosh, I hope someone referred them to the ER. And they're like, I'm going to wait it out, I'm just going to drink a bunch of water. I don't really have insurance, it'll be fine. And everyone's like, go to the ER, go to the ER. And then eventually they're like, oh, I went to the ER, and my creatinine kinase was like, 150,000. And they're like, oh gosh, you might have died had you not gone. But anyway, here, T-colored urine, that's always a warning sign. So if you end up having pretty significant, especially rhabdo occurs, like that's a good reason to discontinue therapy. A lot of cases you may have to switch to a different class of drug in those cases. So again, contraindications, we do not want to use this if people have pretty significant, this kind of relative contraindication, but they have, pre-existing pretty significant hepatic disease. This might not be a good drug for them. Also in pregnancy, because again, this is affecting cholesterol synthesis, and we need cholesterol for things like, cell membrane production. Like who else really needs a lot of cell membranes made? A growing fetus, right? So you don't want to give this for pregnant patients. We'll talk about a drug of choice for hyperlipidemia for those pregnant patients a little bit later, but this is not going to be it. It's going to be category X for those patients, right? And then basically, a lot of these other drugs we kind of mentioned here are going to be ones that will increase levels of a lot of these statins, right? So again, you have to take it on a case-by-case basis depending on how they get metabolized. Crestor or rosuvastatin tends to be a pretty good option for a lot of people because it is such a potent drug, and it also misses a lot of these CYP-mediated drug interactions. But a lot of people are going to be put on simvastatin because, again, if you look at the free drug list, I think simvastatin is either one of them, or lovastatin, kind of depends on which one they can probably get a better deal on. But things like gemfibrozole, which is a fibrate we're going to talk about a little bit later, will increase levels. Niacin can do this as well. So you got to be careful. Again, if your patient's on a statin, check their medication history. Make sure you run an interaction checker to make sure you're not going to give them anything that will kind of tip them over the edge here. They mentioned here, CYP-mediated drug interactions. This will be on a drug-by-drug basis, depending on if it gets metabolized. So, atorvastatin or Lipitor, simvastatin, Zocor are going to be, primary ones you're going to use very often that will be affected by this. And again, patients with pretty significant hyperlipidemia, what else other disease states are they likely to have? High blood pressure. What else? Diabetes potentially. Heart disease, right? So all of these drugs potentially can be affecting this, right? So things like verapamil, we'll talk about that as a calcium channel blocker we can use as an antiarrhythmic or an antihypertensive. Amiodarone's an antiarrhythmic. So again, all these drugs are other things that patients might be on, and again, will guide your decision on what statins will be best for them. Grapefruit juice, why do you think that's on there? And you ever heard like don't give grapefruit juice with your medications? This goes back to that drug interaction, right? So again, and a lot of older people, they like to drink grapefruit juice. Anyone know why? Their taste buds are dying off basically, and this is the only thing that can like elicit a response out of them. So like my grandparents loved grapefruit juice, but my grandfather had really significant heart disease, had stents placed probably like half a dozen times, it felt like, and so like he just could not drink grapefruit juice anymore because of the fact he was on statins that had a drug interaction there, and that will actually inhibit 3A4. It also inhibits, you guys remember I talked about a protein called PGP, that P-glycoprotein. It's also responsible for kicking drugs back out into the GI tract and prevents them from being absorbed. If you inhibit that, that also leads levels to rise as well. So grapefruit juice can be very dangerous. And again, it seems pretty innocuous in and of itself besides the taste. But that's one of those things where levels can rise pretty significantly. You can see, risk for hepatic injury, see risk for rhabdomyolysis. So be careful with that. Yes.
So with genetic testing, can you do like find out if you're fast metabolites, if it's statins, or like does that help you with like this?
That typically, because you don't really see a lot of genetic variation in like 3A4 metabolism necessarily. There's some other drugs we'll talk about where that might be more important, like we talk about like acetylation of certain drugs. When we talked about isoniazid. Remember that can cause that rash-like reaction. Like you may be able to test for it to see if someone's a slow acetylator versus a fast acetylator. That could be one thing. We have, when we talk about warfarin as an anticoagulant, that's a big one where you can actually check for 2C9 because there's a lot of mutations in that enzyme. So we'll talk more about that. But statins is not really a big avenue, at least as far as I know, has not seemed to be a big avenue for research for that. Yeah. Usually, if you're concerned about 3A4 interaction, you switch them over to one that's not mediated by that enzyme, essentially. Yep. Yep. So again, as far as place in therapy, statins are going to be your most efficacious, best tolerated out of this group of drugs. They're going to be first-line therapy unless there's some other contraindication to get your LDL down. Again, this had the most studies behind it, the most evidence to illustrate their benefit. Again, I'm not getting paid by any of the statin manufacturers. I will accept payment though if they ever wanted to sponsor me, but would come with like a big puffy jacket that says like Lipitor on the back or something. But until that day happens, these are just good drugs, and again, they should probably like put this into the water supply so everyone get their LDL down, and like probably like Zoloft or something for everyone's anxiety and depression, and that would fix probably half the world's problems out there. Everyone would live to be 100. So. So if you couldn't use, say, a statin, or maybe you're not getting really the results you're looking for with statins alone, we can also add on some of these other drugs. And so the first one we're going to look at is a cholesterol absorption inhibitor. The main drug in this category is going to be Ezetimibe or Zetia. So the way this one's going to work is actually by blocking intestinal absorption of cholesterol. So again, you can see that once ezetimibe gets absorbed, it'll actually work within the enterocytes to block absorption of not only the dietary fats that are coming in, but also some of the bile salts that you're going to be spitting out. Because again, that's another significant source for cholesterol reabsorption. If you can block that, then again, you just kind of excrete it in the feces. You don't have to worry about absorbing it in the first place. So that can be a very effective way. Again, would this work synergistically with the statin? 100%, right? So there's actually, again, you're attacking it from two different mechanisms. One, you're blocking reuptake of cholesterol, preventing it from ever getting to the liver, which again will have this very similar effect where you're decreasing the concentration intracellularly. You're going to have more LDL receptors being expressed, and then statins can do it from the intracellular side as well. So again, that can be very beneficial, very synergistic, which is why you actually see some combinations that include like simvastatin and ezetimibe already. It's called Vytorin. It's actually a combination drug you might see out there. So again, by having decreased intestinal delivery, increased expression of the LDL receptors, and so that's going to help us to clear the blood. You're going to have less cholesterol content to kind of help with those kind of atherogenic particles there, right? The other benefit here is it kind of limits a lot of systemic exposure, so you don't see a ton of side effects associated with this because it's mainly going to be kind of sequestered to like the liver and the biliary tract, and there's some enterohepatic recycling that happens with this drug as well. That can be useful for kind of extending the half-life a little bit. So again, working both on dietary and also the produced cholesterol that's coming out from the bile tract. All right. So again, I mentioned, ezetimibe you find it by itself, and sometimes you'll see it in combination with like simvastatin for Vytorin. Again, if one drug's not working by itself, this is beneficial because what's the benefit of having these two drugs in one pill? Yeah, compliance is the big thing, right? I can give you 2 pills, but again, it's easier for a person to take 1 pill a day versus 2, so compliance is going to be a little bit better, generally speaking. So as far as drug interactions go, you won't see as many issues here as you do with the statins because, again, it's not going to undergo CYP enzyme metabolism, which is going to be kind of a benefit here. And really nothing to note really as far as the pharmacokinetics go. So for the most part, very well tolerated. Not going to be nearly as effective as your statins are going to be, but it still can be a good adjunct to a statin if that doesn't get you where you want to be with just that one drug alone. So typically you'll see an additional 15 to 20% LDL lowering when added to a statin. So again, pretty significant effects there. And the nice thing here, no real drug interactions, no food drug interactions to really note from that standpoint. We'll talk about a few of these. You have to be really careful about when you time the ingestion of around food or around other medications. So we'll talk about that a little bit later. For the adverse effects, so you can see some GI-related effects, right? Does anyone ever remember that over-the-counter? It became over-the-counter, but it's called Ally. Is it a weight loss medication? Remember how it worked? Yeah, so basically prevented not just like cholesterol, but more specifically blocked all fats from being absorbed from the GI tract. So you prevent the fat from being absorbed. You prevent a lot of the calories from being uptaken. But where does the fat go? Into the stool, right? So does anyone remember the recommendations they had for like side effects go for Ally? Practically wear a diaper, but wear dark colored pants, bring extra pants with you because you'd have these like really foul, oily stools that would some people could not control that because of the high fat content there. This would not be as significant as that, but just be aware that having some increased cholesterol being in the GI tract, you could see some GI upset related to that. This won't be as significant as our resins, as we'll see in a little bit later, but just be careful with that. Not significant. You don't have to tell your patient where your depends when you're taking this medication, but some GI upset would be expected. And also you may see a little bit of synergy here if you had someone with like say hepatic disease already. This could have some synergistic effect with your statins, maybe some bump in your LFTs. As far as contraindications go, again, we need cholesterol in a pregnant female to make sure they can use that for the fetus. So again, probably avoid this in pregnancy. Again, if they have hepatic disease or myopathies, just because of that risk with the statins there. But again, otherwise pretty well tolerated. Most of these are going to be relative contraindications. As far as drug interactions go, one of the things you will see is that by blocking the effects of kind of recycling these bile salts and affecting the biliary tract, you also see that the fibric acid derivatives, which we'll talk about a little bit later, they can cause cholelithiasis, and so this can exacerbate if you did ezetimibe plus a fibric acid derivative. So again, that would be a risk, especially if you have patients who had kind of pre-existing history of gallstones, things like that. That could be a problem there. As far as things like antacids may be able to decrease, but again, most of these are not going to be super clinically significant for our purposes. Just be aware of that the fibric acid derivative effect. That's kind of the one, probably most clinically relevant one. Okay, so then moving into our fibrates, the next class. We have things like gemfibrozil, we have fenofibrate or tricor, and then also the bezafibrate. This is the newest one out of the group. This is one I have kind of the least experience with. Probably still pretty expensive if I had to guess, and still brand name. Most people either get put on gemfibrozil or fenofibrate. It's kind of the most common fibrates we use nowadays. So the way that these drugs are going to work, again, a different mechanism than what we saw with either ezetimibe or with the statins. This is actually going to be working on this PPAR alpha, which is a nuclear transcription factor. So it's going to be working within the nucleus, and basically it increases fatty acid oxidation. Is going to lead to a decrease in those triglyceride-rich VLDL particles, which basically means you're going to have really good effects on your triglycerides. So this is kind of the nice thing is, depending on your patient, depending on what their individual issues are, maybe they just have an isolated hypertriglyceridemia. There's specific drugs we can use just for that, versus if they're kind of have all their numbers are kind of out of whack. And so this can be useful if you need to add this on as an adjunct, or if they have just kind of one isolated problem. But the fibrates are going to be really good for triglycerides. They're also going to be pretty decent for helping to increase levels of HDL as well. Again, this is mainly due to increased expression of ApoA protein, which is going to be expressed on the HDL molecules themselves, right? So I think it can be very beneficial. The main thing is it activates that PPAR alpha, increased triglyceride or fatty acid oxidation. So again, I'm getting rid of more of those the VLDL particles. The big thing to note with these is that you're not going to have a ton of CYP drug interactions, which is good. Maybe a little bit of bezafibrate. It's kind of a minor substrate, so I really wouldn't worry about this one too significantly as opposed to your statins. And nothing really significant as far as kinetics go that we need to really worry about with these drugs in particular. But some of these you will end up taking with food, by taking it prior to breakfast or dinner. That can be useful to help increase absorption, which can be beneficial. Levels get up higher, have better effect on those triglycerides. And again, most of these are going to be either being twice a day or daily. They have a pretty decent half-life there. Now, as far as looking at their clinical effects, what you're going to see is that total cholesterol, which again is going to be made up of both your HDL, LDL, and your triglycerides, pretty modest effects here, lowering it maybe about 15% or so. There's a table later to kind of compare all the different classes. 15 to 20% lowering LDL, kind of okay. But it should be HDL, not HCl. Increased by 10 to 35%. That's pretty significant. And then lowering your triglycerides by anywhere to 20 to 50%. Again, the higher triglycerides are to begin with, the bigger effects you're going to have on this. So someone had just a isolated hypertriglyceridemia, this could be a really good option for them to help get those levels down. So you will see some gastrointestinal effects as the primary side effects, and also this can exacerbate cholelithiasis, as I mentioned with the ezetimibe. This can be kind of a synergistic effect with that. So if they have a history of gallstones, it may not be the best option for them, depending on how significant it is. And you could see some myopathy, so you could have, again, if statins are doing this plus the fibrates, you can see some issues there. Again, this will be contraindicated in pregnancy. Again, there's really only one class of drugs we'll use in pregnancy, which we'll mention in just a few minutes. Existing gallbladder disease, you want to avoid them, and they already have pretty severe hepatic or renal dysfunction. Again, you would accumulate drug and see more likely these myopathies and other kind of side effects. So some issues you can run into with drug interactions. You want to be careful with adding fibrates to an HMG-CoA reductase inhibitor. There is interaction where you can actually see increased levels of your statins by mixing these two together. So it's a relative contraindication. Generally, you can try to lower your dose of one or the other drug to overcome this, but just be aware if you ever add on a fibrate to a statin, you need to monitor for side effects and let them know that, hey, if you start to have these myalgias, if you start to notice anything, you need to come back and we can get this kind of checked out and fix your levels up. Mentioned the cholelithiasis with the ezetimibe. The same thing can happen here with the bile acid sequestrants, because this is another group of drugs that are very significant for binding up biliary cholesterol. Again, primary place you're going to use this is if they have a triglyceride level, say greater than 1,000 milligrams per deciliter, or if they have low HDL. This would be a good drug for those patients. So it's kind of the primary places. This would not be the first drug you go to if you need to lower someone's LDL. Okay. All right, notice here I'm spending less time on these other classes of drugs than I am the statins, because statins, again, are going to be your go-to drug. These are kind of good adjuncts. So again, spend a little less time on them just because they're not going to be as clinically as important. Okay, now, next we have our bile acid sequestrants, otherwise known as the resins. So what do you think these do? Sequester bile acids. On point. So essentially what this is going to do is this is going to be, obviously all of these have been oral medications thus far. This is going to work in the GI tract. This is going to be ingested. And again, what time do you think you'd want to, when does your body spit out the most bile salts? Around mealtime, right? So again, you're going to take these drugs around mealtime because that's when you're going to be expressing the most bile salts from the biliary tract. So you're going to have these drugs come in. They're going to bind up those bile salts, and then they're going to not be able to be absorbed because the molecules will be too big at that point, and they'll be excreted with the feces. So again, what you might imagine is the main side effect here. Yeah, so GI effects are going to be the big thing. We'll talk about that in a second. But also potential cholelithiasis because it's affecting the biliary tract. But again, by decreasing the amount of cholesterol that you can recycle from the GI tract, you're going to end up lowering the actual LDL concentration, or lowering the cholesterol concentration within the hepatocytes. Again, you're expressing more LDL receptors. You're going to be able to clear more of that from the blood. So ultimately, that's kind of the net effect we're going to see here. So, again, not absorbed from the GI tract, which is going to be one of the big benefits here. This is going to limit systemic side effects for the most part. Most of them are going to be kind of limited to the GI tract, and this is why this is going to be approved for not only children, because again, you see a lot, pretty limited side effects with them, but also in pregnancy. So if you had to treat someone's hyperlipidemia while they're pregnant, this would be the go-to drug for that. Okay, I think it's one of those things where you're kind of looking at risk-benefit analysis. So you're kind of looking at, generally you want to limit drug exposure for most of your pregnant patients, but if you had to use something, this would be the drugs to use. Again, now, do we ever use statins in children? Absolutely, but again, studies are very difficult to do in these protected groups like children, and so we don't have a ton of studies to say that yes, statins are beneficial for children, but we kind of know that eventually they're going to turn into adults. So it'll probably some of that data is translatable. So we still will give it to kids, but this one actually has an approval for that, so it could be an option. Okay, so the three drugs in this category include cholestyramine, cholestyramine, and cholecyvalin. Now, usually a lot of these drugs that we're giving are going to be like in the milligram range. These end up being given as grams, so the dose is much bigger because they have to have these powders that you're going to be ingesting. They have to bind up these bile salts as they get expressed from the gallbladder. So you can kind of see here, 5 grams twice a day, 2 grams. I kind of equate the powders to, anyone ever taken like Metamucil, like a fiber supplement? Very similar to that. So again, what's kind of the texture of like those fiber supplements? Pretty gritty, not super pleasant to drink, and so this kind of goes the same thing. So it may not be super tolerable for your patients. Some people have a really bad kind of texture issue where they have a hard time swallowing things that have kind of this gritty kind of texture. We can do things to mask that, as we'll see in just a second. But in general, most of them are going to come these powders you're going to have to mix into a drink and then ingest. Again, most beneficial effect is going to be during mealtime, usually right before a meal. That's when you're going to have the most bile salts being excreted. And again, increasing, you're only going to see, these drugs are going to be kind of wimpy compared to like your statins, and increasing the dose generally only leads to more side effects more than just, you don't really see that same kind of linear decrease in your LDL like you would with like a statin. Typically you can mix it with water, but it might not be super appetizing to your patients, or you can mix it with fruit juice. That can help mask the taste a little bit better. If you do it like in something kind of pulpy, so if you have some nice orange juice with some pulp in it, that can help to kind of mask that texture a little bit, and that might make it a little bit more tolerable for your patients. And typically take it within an hour of a meal, and you want to separate it from other medications, because what could be a potential issue here? They'll bind up other drugs, right? So they're not going to be just specific for bile salts, but they could also potentially bind up other medications. So it's going to be one of those things where you need to separate it out by a period of time. Otherwise, you can end up having decreased levels of other drugs, can lead to ineffectual therapy. Main side effects are going to be within the GI tract, so lots of bloating, flatulence, fullness. So again, if you imagine being pregnant and then all of a sudden now you're adding on a drug that's going to cause more bloating, flatulence, fullness, like they're not going to like you very much. So in a lot of cases, you may just kind of hold off and just say, well, 9 months of mildly high lipids, probably not a big deal. we'll treat you again when you come off, when the baby's born, things like that. So again, it's going to be kind of a value judgment there. It can also lead to malabsorption of some fat-soluble vitamins. This is going to be with more kind of chronic use. You guys remember your fat-soluble vitamins are A, D, E, and K. This can also affect things like folic acid. So potentially, anemias could develop from this, theoretically. And then one of the other things you want to watch out for is that they already have high triglycerides. This can actually exacerbate that and actually have a modest increase there. So you want to be careful with that one. Again, look at it on a patient-by-patient basis. Also, you have some calcium issues here. We can actually end up having increased calcium excretion because more of it's going to be stuck in the GI tract as it binds to the resin and gets eliminated. So, all right. As far as drug interactions, again, I mentioned this is going to be primarily due to them being bound up, binding to other drugs, and they will get eliminated through the feces. So things like digoxin. Again, I mentioned that most of these patients with hyperlipidemia are going to be on other heart medications. So digoxin is a big antiarrhythmic we'll talk about. Warfarin being an anticoagulant, beta blockers, thyroxine, which we use for hypothyroidism, thiazide diuretics, all of these can be end up binding up. So the rule of thumb is you can take your medications, other medications, an hour before the resin, or you need to wait 4 hours after the resin's been administered to take your medications, right? That gives it time to kind of clear through the GI tract, kind of gives it a little bit of a lead time, so the other medications will not interact, okay? So be careful with that one. As far as contraindications, if they already really have high triglycerides to begin with, you probably want to avoid these because, again, you can just end up seeing increases in those levels. You want to watch out for that. All right. So they're placed in therapy. They're the safest drug from a systemic standpoint because they have no systemic absorption, so that can be good, but very poorly tolerated. So compliance is not going to be super great for these patients. And then generally, you're either going to use it for like a pregnant patient or in conjunction with a statin if you needed, say just increased reduction in your LDL, or if they really just need a mild reduction in LDL, this could be a decent option for that. You're going to see that before the guidelines really focused on getting your LDL down to certain goals. So I heard some people say, oh, less than 100 or less than 120 or something like that. Those have kind of gone by the wayside. Nowadays, we're going to see that the guidelines have shifted to a different focus, and we'll see that towards the end of this presentation here. But the next group of drugs we're going to talk about is niacin. Niacin is actually a B vitamin. So again, most of the niacin products you can find, you can go and buy a lot of these off the shelf at your Walgreens, or even if you go to like a GNC or something. Like a lot of these get sold as herbal supplements. All right, so this can be a decent option for patients who say, I really don't want to take a medication, but you really want to get their, try to get their cholesterol in check. Like this might be a decent option for them. It might feel a little bit better. Again, not nearly as effective as the statin is going to be, but it can be an alternative. You can see nicotinic acid. It can also be used as an anti-lipemic, so again, it'll have the same effect as niacin. But if you ever see niacinamide, this is not going to be effective, right? So again, if you're going to be recommending this, make sure you're recommending the correct form, because it can be very confusing when you're looking at a row of herbal supplements. You're like, well, which one do I take? Make sure it either says niacin or nicotinic acid. So you're going to find that there's several different forms available. There's going to be immediate release, and there's going to be extended release products. Typically, what you're going to see with immediate release products is more side effects. We'll talk about kind of the unique side effects you see with niacin. Typically, we like to focus on using extended release products because they will allow for fewer systemic side effects. These kind of acute side effects we'll talk about in just a second here. There's also this inositol niacinate, which could also be used potentially as well. This one doesn't get used very often. The most common prescription product I see is probably this Niaspan, but obviously there's going to be some supplemental products that you can get out there as well. So, right, and so again, I'll talk about why products. Basically what this is going to help to do is you're going to see that by decreasing the amount of free fatty acids that are available to the liver, this is going to help to decrease synthesis of our triglycerides. And so this is going to be another one that's going to have pretty decent effects on triglycerides and reducing that, but it's also going to help to increase HDL. So one of the primary things we use our niacin for is to increase HDL. So if a patient had, their only issue is really low HDL, which we know HDL to be cardioprotective, right? This is one of the things you want to get high enough levels on. You could potentially use niacin as an option for that. Kind of modest effects on LDL, but HDL is the primary benefit here. So imagine by decreasing mobilization of these fatty acids, have less triglyceride synthesis here. So again, not only you're going to have a few more LDL receptors being expressed on the hepatocyte, but also you're decreasing these VLDLs, which again are primarily triglyceride based. So you're lowering those levels within the blood itself. Then as a kind of a downstream effect, you have an increase in HDL. So those are the other big benefits there. Okay. So again, just looking at like a dose response curve, typically niacin gets added on to other medications to get kind of a synergistic response here. You can notice here HDL with just timed release or extended release nicotinic acid, adding that on. Actually, this primary point here is that if you have immediate release, you typically get more effect out of it, but more side effects. So most people can't tolerate the side effects, as we'll see in a second. So they end up taking usually extended release. So a little bit more modest effect, but typically it's okay for most patients. So you can see here that obviously the extended release products are going to have a little bit longer half-life or time for absorption. And again, no CYP drug interactions, which is another big benefit for utilizing these to kind of bypass a lot of those issues. So obviously extended release products, you only have to take one time a day, which is another benefit, especially for compliance sake. And again, most of the herbal supplements you're going to find out there tend to be extended release products, even if they don't directly say that. They're usually in a salt form that's going to be less likely to cause these side effects. So you say, what are these side effects you've been alluding to? I'm on the edge of my seat, wondering. So you end up seeing a lot of this this cutaneous flushing that occurs here. And most of this is due to prostaglandin synthesis. So again, prostaglandins tend to be vasodilatory or vasoconstrictive. Yeah, vasodilatory. So you end up seeing prostaglandins being produced in higher numbers, and it causes a lot of cutaneous flushing. They get very hot, they get very sweaty. You can see a lot of GI upset related to this, and so it can be very intolerable to many of your patients. And so what you can do is actually pre-medicate with aspirin. So if someone was more prone to getting these side effects, you can utilize aspirin. Why would aspirin be useful? Prevents prostaglandin synthesis by inhibiting cyclooxygenase. So that would actually make sense. So I can give cyclooxygenase, and that's a typical drug we can use. Ibuprofen probably would work as well, but aspirin is kind of historically what's been recommended most often. So I can tell you kind of a funny anecdote. When I was in pharmacy school, we were on rotations. I was at a family practice clinic for a month in Gainesville, and so I had a friend who was also in a different site in Gainesville as well. So we were kind of carpooling back and forth to where we were living at the time, and she was with another couple of pharmacy students, and they got really bored. I guess their practice wasn't very busy, and so they said, well, let's do a niacin challenge. Let's just do as much immediate release niacin as we can just to see how we tolerate. We want to see what our patients have to go through. So they took a super therapeutic dose, needless to say, and so I went to go pick her up. She got in the car. She was red from head to toe. She had vomited like 3 times before then, was sweating profusely, and was just the most miserable person I'd ever seen in my life. I said, oh, you probably didn't take any aspirin with that, right? And she's like, no, I did not take any aspirin with this. Please let me go die in a bed right now. So anyway, so she eventually recovered. Probably took about 24 hours to get her back to normal, but she did fine. So again, this is what your patients might experience. Aspirin can be very useful in helping to pre-medicate with that. Again, this is why a lot of herbal supplements have moved over to using a different salt form or an extended release preparation that kind of mitigates a lot of those effects. Because if every time you took an herbal supplement you got really sick like that, you probably wouldn't take it, right? With kind of larger, more chronic doses, you could see increases in things like glucose, your LFTs, uric acid. So if you had a gout patient, that could be problematic, and this kind of decreased glucose tolerance. So I mentioned a lot of your patients might also have diabetes, so it's important you want to make sure that they have their sugars under control, and niacin may affect that, right? Again, typically extended release products tend to mitigate a lot of those side effects. As far as contraindications go, if you had chronic liver disease, again, you probably not want to exacerbate that because niacin can worsen that. And then any history of peptic ulcer disease, symptomatic gout, all these kind of make sense when you go back and think about some of the side effects you can see with that. And as far as interactions go, certainly alcohol can already have a kind of flushing effect due to the acetaldehyde that gets produced from its breakdown. So this could exacerbate if you include niacin with that. And then the other thing, I put a lot of herbals here. The big thing to note is that due to the hepatotoxic effects, you can also see that this may be synergistic with some herbal supplements. And again, that's why it's really important to do a really thorough medication history, because if this is something that your patients would like to pursue, if they want to use niacin as an herbal supplement as opposed to like a statin or something, figure out what other herbal supplements they're also taking, because again, there's not as much regulation around herbal supplements as far as production goes, and some of these have been found to be hepatotoxic, especially if you add them onto other drugs that are hepatotoxic, right? So just ask what they're taking. These are just some examples. I'm not going to ask you specifically on a test which ones of these can be hepatotoxic. Just know that patients taking one herbal supplement, they may be more likely to take others, and so you want to give the full medication history to avoid some of these issues. Usually when a lot of herbal supplements are removed from the market, typically it's due to cases of hepatotoxicity that occurs, right? That's kind of the most common thing you see the FDA citing in those cases. Again, typically you're going to use this for patients who have either elevated LDL that you're adding kind of as an adjunct to something like a statin, or if you need to kind of get their HDL up, this can be another place in therapy where this can be utilized. And there's some combination drugs here. You can see a statin plus niacin. This is Advocor is just one example. Again, you get pretty good reductions in your LDL, good increases in HDL, and then some pretty decent reductions in triglycerides. So again, synergy can be very powerful here when you use these combination products. All right, any questions from the first half? Feels pretty comfortable. Okay, so this is the newest class of drugs that we use for hyperlipidemia. This is called our PCSK9 inhibitors. I'm not going to show you what the actual abbreviation for PCSK9 is. I couldn't tell you off the top of my head. I just know them as PCSK9 inhibitors. Almost sounds like a robot from Star Wars or something. But two drugs in this class. Some things to know about them. So you have alirocumab or Priunt, and you have evolocumab or Repatha. So what do you kind of notice about these drugs? They're MABs. They're monoclonal antibodies. So if you notice here, what type of device is this? You know what it's called typically? Usually call it like a pen device. So usually like they're injectable products, right? So they're proteins. They cannot be taken orally because otherwise the GI tract would just destroy them. So we use these pen devices, and so you see a lot of insulin products that get dispensed in these pen devices. It's very useful because patients can basically dial in the dose here at the top, and then they'll usually put like a replaceable needle device at the bottom, and then inject the product. You can see kind of the button here; they would inject that usually subcutaneously in most cases. So again, this is something they can take home, inject themselves, obviously with proper education, all that good stuff. So these tend to be, as far as price goes, how would you expect them to compare to like something like a generic statin? Very expensive. These are super expensive. So and also we have the kind of the least amount of experience with them. So again, the guidelines, typically what you're going to find is whenever you have like a new kind of like brand new class of drugs, it takes some time for them to kind of get incorporated into guidelines, because again, it takes time to get those studies, to look at the efficacy, to look at long term, because when you're looking at things like cardiovascular death, like how long do the studies need to go on for? Decent long, yeah, unless you're using some kind of surrogate marker for that, like you need to wait till people start dying, right? So that's kind of the thing where like the Framingham heart study has been going on for decades now. We have a lot of data to look at looking at efficacy for a lot of these drugs. This, on the other hand, will take some time to kind of get into the typical use for antihyperlipidemia. But we do know they are super effective at dropping LDL, and basically you have this PCSK9 enzyme, and then basically it's responsible for processing hepatic LDL receptors. So in order to remove those LDL receptors that are at the surface of the hepatocyte, this PCSK9 enzyme will come along and sort of that process of removing them. If you have a monoclonal antibody, this is an antibody that's targeted specifically at that enzyme, it will bind it up and basically render it inactive. So by blocking that enzyme, you keep the LDL receptors active for longer, and so they are more available to reduce those LDL concentrations. So you can see very significant drops in LDL, maybe 43 to 58% drop in those levels, which can be pretty significant. Again, it's injectable only, which is not nearly as convenient as taking a pill, very expensive. And then obviously with it being a protein, hypersensitivity is going to be the biggest adverse effect, most serious adverse effect you're worried about. It's kind of interesting. There's actually some patients who had their LDLs drop to undetectable levels when they were measuring it. And one of the big things they're saying on the package inserts is like, we don't know if this is actually unhealthy for patients. We just know we dropped it down super low, but it may happen. I don't know. We'll see. Wait 10 years to find the studies that say this actually kills people and they'll remove from the market potentially. But in case you ever see someone on it, this is a big thing to worry about for right now. So looking at, and again, I kind of don't include the PCSK9 inhibitors on this slide just because, again, they're still super new, so we're still trying to figure out a lot of kind of their effects here. But this is a handy slide to kind of show you the primary effects you're going to find with a lot of these drugs. So again, with statins, primarily you're going to see big drops in your total cholesterol, and again, I'll show you how to calculate that, but it's mainly comprised of your LDL, your HDL, and your triglycerides. So you're going to see pretty significant drops in LDL, decent, kind of okay increases in HDL, and decent drops in your triglycerides, right? So this is kind of good all-purpose drug for getting someone's lipids back in order. Your resins are going to have okay effects on LDL, but really will have either no changes to triglycerides or may slightly increase them, right? So you want to avoid this in patients who already have high triglycerides to begin with. Nicotinic acid, the big thing here is going to be for triglycerides and also HDL, so that's kind of its big claim to fame. Fibrates, again, probably also good for HDL and also triglycerides as well. So those kind of have a similar place in therapy for these patients. And then Ezetimibe, mainly going to be focusing more on LDL, maybe a little bit in triglycerides, but again, this is a good adjunct to if you could not get them under control with just statins alone, right? So you can kind of know the general, you don't have to know the percentage numbers, but just have an idea of like, hey, I had a patient who had had triglycerides that were the only problem with them that were high. What drug would be most appropriate? And I would have nicotinic acid as an option. I would have a resin as an option. You would say, well, no, don't use the resin because that could actually increase it, but the nicotinic acid might be a good option, right? So those are kind of questions you might be asked. So again, I'm not going to have you calculate total cholesterol. I just kind of want to show you how we actually figure that out. But again, it's going to be HDL plus your VLDL plus your LDL. And the way we would get VLDL is basically by taking the triglycerides and dividing that by 5. Right, so by doing that, you get your, and again, most of the time, the lab will report total cholesterol to you, so they kind of do the math for you already. But just know that's kind of where they're getting that kind of surrogate for your VLDL concentrations by looking at the triglyceride content of the blood, right? Again, if your triglycerides are too high, it tends to kind of skew the numbers a little bit and screw that up. So this is, they probably have some sort of calibration for that with their lab test, but just know that's usually when they're doing it if it's less than 400. Again, so that's how you calculate it essentially. Typically you find HDLs, one of the big things that it responds to is exercise. So again, think about non-pharmacologic therapies that can be very useful for them. And the old way we used to treat hyperlipidemia is we're shooting for goals and the actual numbers. So we used to shoot for, LDLs less than 100 would be considered optimal. We'd shoot for HDLs that were larger than say 60. If it was less than 40, that was also a risk factor for cardiovascular disease. We want total cholesterol less than 200, triglycerides less than 150, right? So we'd have these goals here that we were shooting for, and you can mix and match drugs as needed to try to get your patients to goal depending on basically how bad they were to begin with. Has anyone ever seen like really lipemic blood before? If you ever see it, it's really kind of cool because the nurse will come up typically and be like, hey, I drew this guy's blood, and he probably just ate like a big fat hamburger prior to coming to the emergency department for chest pain. But what you'll see is it actually looks like almost like you mixed in like mayo or something with the blood. So it has this kind of creamy, kind of white reddish kind of color. So it's very interesting if you ever see it, you're like, that doesn't look normal. It's probably because the blood's super lipemic, a lot of triglycerides, a lot of cholesterol that's in there. So you can look up pictures of it. It's kind of neat looking. It's like you mix ketchup and mayo together, kind of that color. I think it can like change blood color. So like, anyone know what can cause chocolate brown blood? So there's a condition called methemoglobinemia. It's where actually you can change your hemoglobin, change the iron, basically the charge on it, and it actually causes your blood to carry water instead of oxygen, and that turns a very dark color. So if you put it like on a bed sheet or something, you would see it look like kind of dark chocolate color. So again, a little bit of trivia for you. Anywho. The newer guidelines that we have, and these were published back in 2013, is that we not focus so much on the numbers. We just really want to get you the numbers as low as possible safely, right, considering side effects and things like that, because we know that typically lower is better for things like LDL, for your triglycerides, because we see lower risk for atherosclerotic progression. We see less risk for cardiovascular death caused by this, right? And we know this is heart disease is one of the leading causes of premature death in America. So what has changed? Basically, we're going to look at statin usage as our go-to drug, and we'll talk about moderate intensity versus high intensity statins based on their risk factors. So how likely are they to have cardiovascular disease? Do they already have it? They obviously are a bigger risk. What other comorbid conditions may predispose them to having issues with cardiovascular disease? So we'll look at that. And again, we're not titrating to a specific LDL goal. We're titrating to basically the highest dose of a statin we can get that the patient still tolerates before they start having kind of intolerable side effects, essentially. Okay. Obviously, when we're measuring LDLs, we're doing this more to measure compliance, right? Because again, if the patient's not taking the drug, LDL probably is going to be high, right? So that's going to be one of the things you're going to be shooting for, not necessarily getting it less than 100, less than 80, whatever it happens to be. You're not shooting for that necessarily. So basically, we'll talk about these patients who have ASCVD, so this is atherosclerotic cardiovascular disease. So we'll talk about those definitions in just a second, what kind of constitutes that. But patients who have evidence of already having this atherosclerotic cardiovascular disease will be these are the major groups to benefit from statins. These are the most likely people to have, mortality decreases and have extended life because of this. Those patients, we'll talk about those definitions in a second. If you already have a high LDL, so like say greater than 190, this would consider to be another beneficial group. Patients with diabetes, right, usually type 2 diabetes, what we're kind of referring to here. If they're older, so say 40 to 75 years of age, and they have high LDLs to begin with, and without ASCVD. So these are kind of the people who are developing kind of risk factors, but they haven't actually had evidence of cardiovascular disease just yet. They can benefit a lot from this. And then those without any kind of clinical evidence of cardiovascular disease or diabetes, their LDL levels are not too high, but they have this 10-year estimated risk of having ASCVD within if greater than a 7.5% chance of developing within the next 10 years, right? Because again, we're not thinking about statins as being beneficial necessarily in the short term. We're looking at the kind of the long game here. We want to make sure patients are going to be living for as long as possible, and these drugs are going to help with that. So basically, we're going to be looking at patients. We're going to kind of risk stratify them to decide whether or not they're going to need kind of moderate intensity or high intensity statin therapy, right? So basically, I'm trying to see where they have the definitions here. I think I have it on another slide. Basically, this is going to include things like they've had previous heart attack or they have like angina, evidence they're having cardiovascular disease to begin with. But basically, you're going to look at the age of the patient. You're looking at the comorbid conditions like diabetes, and we're going to do these risk calculators. I'll show you that risk calculator in just a second here. But say, for instance, patient already had a history. Say they already have a heart attack. And now they need statin therapy. You would look and say, okay, well, is their age less than 75? Yeah, let's go ahead and do high intensity statin because we know they're going to benefit and have mortality benefits from that, right? Now, if they can't tolerate really high doses of these statins, then you titrate down to see what they can tolerate. And we'll look at what we consider high intensity versus medium intensity statins in just a second as well. You look down, okay, well, maybe they don't have ASCVD. Let's look down and see what their LDL concentrations are. If they're greater than 190, again, they're going to be potentially benefiting from this. So again, they're going to require high intensity statins, okay? If they didn't have that high level, maybe go down and look to see if they had diabetes, right? And they're aged 40 to 75. We know that these people are also at risk. You can try starting like moderate intensity statins, but otherwise, if the risk is of developing ASCVD within 10 years is greater than 7.5%, they would be candidates for high intensity. So you're basically risk stratifying patients, seeing what would be the best option for them based on their risk factors, right? And they were missing all this other stuff, but you're looking at they had a greater than 7.5% chance, and they're 40 to 75. Again, they would also be requiring at least moderate intensity statins. So let me show a second here. Now, here's an example of how you can look to see what a person's risk would be within the next 10 years. This is just a calculator I pulled off the Google, and you can see here that it's based on things like what's their gender, like who typically is going to be more likely to have cardiovascular disease. Sorry, guys. Yeah, it's us. You look at their systolic blood pressure, right? So if they have hypertension already, that's going to influence that. Their age, obviously, the older you are, the more likely you are. Looking at their race, so that can have some effect whether you're Caucasian, if you're African American, whatever it happens to be. If you're receiving treatment for your blood pressure, right? If you have diabetes, obviously that's a big risk factor. If you're a smoker, another big risk factor. And then looking at total cholesterol and your HDL. Obviously, having a high total cholesterol will be a risk factor. Having low HDL is a risk factor, right? So you would basically put on all these values for your patient. It would spit out a percentage, the chance that your patient is going to likely develop ASCVD within the next 10 years, right? So to develop like heart attack or angina or whatever other conditions that will be categorized as that. So again, is that a guaranteed risk that your patient is going to develop this in 10 years? No, but it's high enough risk that you look at the potential downsides of the statin versus the potential benefits, and it's like it usually kind of weighs on the side of the benefits of just treating with the statin at the highest dose you can tolerate for them. So what do you consider to be kind of high intensity versus medium intensity? Usually what you're going to find is that atorvastatin and rosuvastatin are going to be kind of your biggest guns when it comes to statins. These are the most potent agents to get your LDL down, right? So atorvastatin, and you notice here that the doses will range depending on the drug you're dealing with, right? So again, atorvastatin 80 milligrams is equivalent essentially to rosuvastatin 40 milligrams. So obviously the more potent agent would be rosuvastatin, right? So because again, you can get a lower dose and get the same kind of effect from that. So again, looking at this, you want to see how high of a dose they can tolerate. If they tried 40 of rosuvastatin and they couldn't tolerate that, then you just back it down, say like to 20, see how they do with that. If they're still not tolerating that, then maybe dump it down to 10. Okay. The goal is to get the highest dose possible. Try to get their LDL down as far as you can, because again, we're not shooting for a goal necessarily. We're trying to decrease that risk over the long term. Yes, sir. Yeah, so I would probably start with something like, say, 20 of rosuvastatin and see how they tolerate it. If they do okay with it, then I'd probably bump it up to 40 at a point. And again, looking at LDL just to make sure they're actually taking it. Because again, there's no one that should be on 20 of rosuvastatin and not have some drop in their LDL. You should see some kind of clinically significant drop there because, again, it's a very potent drug. And you notice here, your moderate intensity statins, you're using lower doses of things like rosuvastatin, like 10 milligrams, right? That would be considered moderate. Any other drugs in here, like simvastatin, pravastatin, all these other statins start to come into play here. The big thing to notice here is that even like things like simvastatin are never going to be strong enough to really get the same effect as you will with these kind of bigger doses of these more potent drugs. So typically, if you need to treat a patient high intensity, like these are the two ones you want to go with, the atorvastatin or rosuvastatin, right? It's Lipitor and Crestor, respectively. You ever heard of those brand names? And again, you can go to even lower doses for the kind of low intensity, but most patients are going to require the moderate to high intensity. Okay, so I may ask you a question. It'll be pretty obvious on a question like, hey, this guy has diabetes and he's 90 years old and his blood pressure is like 900 and he has had a heart attack last week. Like, what should he be on? And you're coming up like, okay, probably high intensity statin therapy, right? So it'll be kind of clear cut whether it should be like a moderate, more high intensity kind of statin situation. Yes, ma'am. Typically, no. These are typically going to be lifelong kind of medication. Now, there could be a subset of patients who say if you're relatively young, have few risk factors, and you get your diet under control, you start exercise, there could be a potential you can come off of. But most patients have led a life of luxury that has led them to this particular state, and most of them are not going to have a huge change in a lot of that stuff, right? Because obviously, lifestyle choice changes are if they can make all that and fix their cholesterol, awesome. They can get rid of their diabetes and their hypertension, all other issues, great. It's not going to be reasonable in a lot of patients, right? Because I'd rather take a pill than actually, get up and exercise. That's kind of the mindset for some of these patients here. So a lot of times it ends up being lifelong therapy.
What's the little plus sign after the 40?
Plus sign after the 40. That is probably a note down in the table there. It's not important for our purposes here. Yeah. Probably saying something like basically like atorvastatin, if you just half the dose, you get the equivalent dose of rosuvastatin, if I had to guess. But you should look at the potencies. There's a whole mnemonic I use to keep track of the potencies of statins, but I'm not going to make you guys know that because that's a little too nerdy, and your pharmacist can tell you that later on. Anyway, so any questions on that? Kind of makes sense? Okay, so as far as statin safety recommendations, again, select the appropriate dose. Follow the guidelines of showing which should you start with first. If you treat a lot of these patients, you'll have an idea of kind of like, okay, I'm going to go with 40 of atorvastatin. I'm going to go with 20 of rosuvastatin. Depending on your patients, you'll have an idea of what you're going to use as you treat a number of these patients. Keep those drug-drug interactions in mind. Typically, rosuvastatin is very good if you have worry about CYP drug interactions because that one is not really CYP mediated, so that's kind of a benefit. But atorvastatin is. So look at their insurance, look what they can actually afford, watch those drug interactions and side effects. Again, if you cannot tolerate high intensity or moderate intensity statins, that's when you're going to start to back them off and use the lower doses, right? So for instance, if you had a patient, you're wondering, what about all those other drugs we talked about? When would you add those on? Typically, if they were on, say, maximal doses of statin, and you still couldn't really get their LDL down, like they're still, pretty significantly high, like say 150, 180, something like that, that's when you can add on another drug to try to help get that down even further, right? Because that the higher the LDL is, the more at risk they're going to be for these atherosclerotic changes over time. Right? Okay, so any questions on that?
Is there an upper limit for HDL?
Not typically, not that I know of where it gets dangerous at any point. Like I said, having it greater than 60 tends to be, a negative risk factor. It kind of lowers your risk for things like heart disease in general. But I've not seen anyone's ever had too high of an HDL. I'm sure there's someone out there, some weird case reported by someone had like an HDL like 100 and they keeled over or something, but not that I know of. Okay. Yep.